UBC, inspiring Uganda.
You are watching the DOCtalk show. This message is from the Ministry of Health with support from partners.
Hello and welcome to the DOCtalk show. My name is Dr. Kamala and I thank you for joining us. Today's episode is about the newly launched malaria vaccine. And joining me today is Dr. Jane Nabakooza, who's a pediatrician and the technical lead at the Malaria Chemoprevention and Vaccine Ministry of Health National Malaria Elimination Program. So this show is brought to you by the Ministry of Health and Kamala Men's Collection. So Dr. Jane, you're welcome to the show. Please introduce yourself and tell us a bit about yourself and your background in malaria prevention.
Thank you, Dr. Kamara. Once again, Dr. Jane Irene Nabakooza is my name. I am a pediatrician and a public health specialist. I work with the Ministry of Health in the Department of Communicable Diseases Prevention and Control. Specifically, I work with the National Malaria Elimination Division, where I am a technical lead for malaria chemoprevention and vaccine. I'm happy to be here.
Thank you, Dr. Jane. So you've got quite a good background in malaria prevention, and we are going to start with malaria. Please give us a bit of context about malaria today in Uganda.
Yes, we all know that malaria is one of the leading causes of mortality, that is death, and morbidity, that is sickness. Simple definition of malaria, it is an acute febrile illness. Acute because its symptoms do not last more than 14 days. And febrile because in most cases the patient will present with a fever plus other symptoms. It is caused by a small germ called the malaria parasite. It is a protozoa. It's called Plasmodium. There are simple types of subtypes of the Plasmodium. I can mention them quickly, but let's not focus there because the main thing to understand is that it is caused by malaria parasites and not by the mosquito. The mosquito only transmits, the malaria is transmitted by a female Anopheles mosquito. When that mosquito bites someone that has the malaria parasites, and then the parasites are transmitted by that same mosquito to another non-infected person, and that person gets malaria. What does it look like currently? What is the picture? What is the situation? To start with, every Ugandan is at risk of malaria. Every Ugandan, wherever you are, you're at risk of getting infected with malaria. I beg that people understand this. There's no one who is not at risk. As long as you live in Uganda, you're at risk. Why? Because I've told you that the malaria is caused by a germ called the malaria parasite. That parasite, same way you enjoy that weather is the same way the parasite enjoys the weather and survives in that weather. But also the mosquito that transmits the parasite thrives well in this kind of weather. And so you'll see that every Ugandan, wherever you are, we live with malaria. Malaria is around us. So, but we have some groups of people that are at a higher risk. That is the children under 5, the pregnant women, people living with HIV/AIDS, the sickle cell disease populations, the non-immune visitors, that is people who come from areas where there's no malaria to areas where malaria is highly endemic. Those people are at a higher risk. They are vulnerable to more episodes of malaria, severe forms of malaria, and when they do get malaria, they can easily die. You'll find that 95% of Uganda, malaria is endemic there. It is always there. And only 5% is where we get epidemics. They don't have malaria, but they can still have some cases, especially if we have turbulences in weather and maybe because of the population movements. And these areas are known. Areas like Kabale, areas like Sebei region, areas like Mbale. Those are some of the few areas. And currently Kampala, you wouldn't relate it to the weather conditions, but to the socio-economic factors. The housing conditions are good. So people are able to prevent mosquitoes from entering the houses. So those are some of the few areas where you find that malaria is not, the transmission is not high, it's very low. And so you'd expect epidemics. It's not very endemic there. So, however, as we speak, Uganda is the third contributor to the global malaria cases. The World Malaria Report of 2024, and that was a documentation of 2023 scenarios. Globally, Uganda contributed about 4.8% to the global malaria cases.
That's huge.
Yes, and were the third next to Nigeria and Democratic Republic of Congo. That has been the situation for about a decade.
Yes.
In that third position. The only thing that changed a bit around that for 2023 is that the cases had reduced. They had reduced from what was in 2022. And when it comes to contributing to deaths, were the 10th. We contributed about 2.8% of the total global deaths. That was still an improvement because in 2022 we were 8th. We were contributing at about 2.9 and we were the 8th. So in terms of mortality, we've been reducing the deaths, and we are associating this with the improved malaria case management, where the care for malaria has significantly improved. Ever since the country changed from using injectable quinine to injectable artesunate, we've been noticing, because that was around 2012, we've been noticing a reduction in deaths because now the treatment outcomes for severe malaria are getting better and better. When that is the global picture, but when you look at the local picture, if you look at our annual health sector performance report of 2023-2024, you realize that whenever you find 100 patients at outpatient department waiting to receive care, about 33 out of that 100, that is 33%, will be because of malaria. So you can see that malaria is still the commonest cause of morbidity. And when you look at admissions, every other time you get 100 admissions, about 22 will be because of malaria. That's about 22%. And then of those, how many die? About 11%. But to quickly put it, every day we lose about 16 people due to malaria. Every day. So you can count in a week how many do we lose. And out of those 16, 10 are children under 5. So you can see that children under 5 are the most affected in terms of severe malaria and in terms of death. So to quickly paint a picture, because this is what guides our planning. The current running plan for the malaria reduction and elimination, because for between 2020 and 2020, between 2015 and 2020, we're talking about control. That was between 2015 and 2020. Then 2020 to 2020, to 2025, we've been talking about reduction and elimination, because we had identified some areas where we thought we could accelerate efforts and do elimination. So just to put it right, if I can start from now, 2020 to 2025, we're talking about reduction and elimination. Then between 2015 and 2020, we're talking about reduction. Between 2011 and 2015, we're talking about we're in control entirely. So, so why did we think about elimination at that time? Because at that time, we had some areas where the transmission was really, really low. Like I mentioned earlier, the likes of Kabale, the likes of Mbale, and the likes of Sebei region. And so we thought those, if we accelerated efforts, we would have malaria reduced significantly to levels of elimination. So why was it that in 2020 we were thinking about reduction plus elimination? If you look at the malaria prevalence is when you get into the population and try to see how many of 100 are carrying malaria parasites. At that time, nationally, every time you encountered 100 people, 9 of them would be carrying malaria parasites. So the prevalence was 9% on average nationally. That was 2019. But there were areas like Karamoja that had very high prevalence. Because Karamoja, they were at 34% at that time. And places like Busoga were at 21, and West Nile was at about 22. But there were areas like Kampala that were less than 1%, 1 to 2%. So you can see that we had variations. But that picture had greatly changed, because in 2014, the average was about 19%, and in 2009 it was 42%. So you can see that there was a change. Maybe when we can come back, we can look at another parameter that guides us to understand the variation in burden in the country. Yes.
Yes, thank you, Dr. Jane. So you've given us a great context on where malaria stands right now in Uganda and globally. And from her description and from the figures, we can see that malaria is still a huge public health concern here in Uganda. So we are going to take a short break, and when we come back, we will go into the newly launched malaria vaccine and how it works and all the details. Dr. Jane is here to give us the details and the science behind this. Thank you for watching the DOCtalk show, and stay with us.
This message is from the Ministry of Health with support from partners.
Since 2015, Quiz Mali Production has been at the forefront of media innovation. Our passion for storytelling and creativity has driven us to deliver over 100 successful projects, making a lasting impact on the industry. With 4 highly acclaimed TV shows, we've become a household name, bringing quality content to your screens. At Quiz Mali Production, we specialize in content creation, digital media marketing, media buying, and documentaries. We plan corporate events, provide top-notch photography and videography services, and offer seamless translations and live streams for your every need. Join the hundreds of satisfied clients who trust us to bring their visions to life. Quiz Mali Production, your partner in media excellence. Visit us at Quiz Mali and let's create something amazing together.
Hello, Kampala, Uganda. In response to the national call of strengthening the traffic security, Good Products Group HGO brand has officially launched the Rider Selection Campaign. Registration is now open. Visit www.riders.hgo.com. Complete your registration now for a chance to win exciting prizes including motorcycles, exclusive HGO gift boxes, and official rider vests, all while promoting safe riding awareness. This is how to participate. Pay the registration fee, invite 3 friends to form a team of 4, and your registration fee will instantly be refunded. Begin your journey of honor today. Don't miss this opportunity. Join the challenge, promote road safety, and become a pioneer rider. For details, visit the official Good Products website at www.hgo.com or call toll free 0800 335 555 or visit our offices at Kingdom Kampala 3rd floor to register now and win prizes worth millions.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back to the DOCtalk Show. My name is Dr. Kamala Ivan, and today's episode is about malaria and the newly launched malaria vaccine. So this show is brought to you by the Ministry of Health and Kamala Men's Collection. So earlier we were talking about how malaria is still of great public health concern here in Uganda. And now we are going to go into the malaria vaccine itself. I'm joined here by Dr. Mary Nabakooza, who's a pediatrician and the technical lead at the Ministry of Health in the malaria chemo prevention and vaccine strategy. So, Dr. Jane, tell us a bit about the complications of malaria. That is, for our audience, the complications of malaria are some of those more life-threatening conditions that happen as a result of malaria. So take us through that a bit.
Yes, after one is infected by the parasite, depending on your immunity, you can keep it at uncomplicated malaria. But for the non-immune groups, they're highly vulnerable that I mentioned. And even for anyone who delays to seek care, you can move on to severe malaria. And a simple definition of severe malaria is when malaria presents with a complication. And normally, it starts with, there are things we can see to know that this complication has set in. For example, and these are normally called danger signs. And some of these danger signs include the following. One of them is you're so weak. You can't do things on your own. You need to be supported. The other is altered level of consciousness. You're disoriented in terms of where you are, in terms of the people around you. To a worse extent, one can get convulsions. All these are danger signs. Then complete refusal to feed, vomiting everything, or if someone is, like for example, right now, Dr. Kamala, your tongue is pink. But if it turns to white like my coat, then you're pale, your blood has reduced. And so these are the things at home that you can see when you're at home. You see that your patient who just had a fever now can't walk. The other is reduced urine output, or if you're passing tea-colored urine or Coca-Cola-like urine. All these are pointers to some of these complications that I'm going to mention. One of the complications that we fear most and is very common is reduced blood amounts. And here you will see the person is not able to support themselves, they are breathing with difficulty, and the color of their tongue has changed. So you now know that the blood has reduced. The other is acute kidney injury. Kidneys by nature are supposed to rid the body of the toxins. We take in food is digested, what is required by the body is taken off, and what is toxic is passed out by the kidneys. So you can imagine if the kidneys are not functioning, it means you're retaining all the toxins and all the poison, and this cumulatively kills you. So acute kidney injury. The other is pulmonary edema. Pulmonary edema is the lungs, the small airways of the lungs. There's some fluid accumulation, and to put it in simple terms, and then they get swollen. That is a pulmonary edema. The other is congestive cardiac failure. A number of organs fail, including the heart. And then here, how you know is that there's difficulty in breathing, there's swelling of the lower limbs, plus a number of others. The liver can also fail. The bone marrow can fail. How do you know the bone marrow has failed? You'll see, you'll bleed under the skin. So you see someone is bleeding under the skin, but you can also bleed into the brain. There are a number of other complications like cerebral malaria. Cerebral malaria, this is when someone is disoriented, like I said. And eventually, once this happens, then if you're not managed well, then you'll die. The patient dies. So so this is what malaria does. And usually the moment you delay to seek care, then that is when you get the complications. And that's why we emphasize that when someone feels unwell in the morning, the next morning should not find them at home without them seeking care, because then that is what causes the complications and then eventually death.
Yes.
There are quite a number. I can't list all of them.
Yes, there are so many life-threatening forms of malaria,
Yes.
as we've mentioned, and you are quite experienced in the prevention and control strategies that this country has taken. So now we are going to go into the malaria vaccine as one of the prevention and control strategies. We have a malaria vaccine that's been a long time in the making, and now is being launched and rolled out. So let's dive deep into the malaria vaccine. What is this malaria vaccine and how does it work?
Malaria vaccine is a vaccine like all other vaccines. It's the 14th that we've added onto the list. I remember our time, for you young, our time we used to know about 6 vaccines, but now they are now 14.
Yes, I know.
Malaria vaccine is the new kid on the block. So the malaria vaccine, there are so far 2 brands that are recommended by the WHO, World Health Organization. The others are still under study. This malaria vaccine works because if you look at the malaria cycle, we have what we call the pre-erythrocytic stage. That's where this vaccine works.
Just for our audience, the pre-erythrocytic stage, that's before the malaria, before the parasite enters into the red blood cell, or?
So what happens is that when the mosquito bites, it will be carrying malaria parasites in the salivary glands. So in that process of biting, some of the saliva goes into the skin. So as it picks the blood, because the saliva contains the parasites will get into the blood circulation. But remember, for them to cause disease, they need to mature at a certain level. So when they get into the blood circulation, then they'll invade the liver. Because it's in the liver that they will develop into merozoites. And then before they can be released now to infect the red blood cells, where they mature further. And then some continue to become gametocytes, and they're picked by the mosquito for the cycle to continue within the mosquito, and then the infection happens again. But others continue on to mature within the red blood cells, and at a certain stage they are released into blood, and whenever they are released into blood, that is when the patient gets symptoms of malaria. And then depending on what kind of parasites, every either 48 hours or 72 hours, there is that release. And cumulatively, if that release continues without one receiving treatment, that's how some people, depending on the immunity, that's how some people get into severe malaria. So what happens? So the vaccine works at that stage where the parasites infect the liver. So it prevents the parasites from infecting the liver. But even those that have escaped and infected the liver, the cells that are infected are also destroyed. That's how this vaccine works. So that means there will be no continuation to the red blood cells. That's why it's pre-erythrocytic.
Yes.
Pre means before, erythrocytes are red blood cells. So that's how it prevents severe forms of malaria, and that's how it prevents death. So this vaccine is going to work by preventing severe forms of malaria and death, but it is not going to prevent infection, because you can see the parasites can still enter into blood. Okay, so that is where it works. So there are two vaccines that have been very well studied. Malaria vaccine has been studied for over 30 years in different countries, including African countries. The pilot was done in 2019 in 3 countries, that is Malawi, Kenya, and Ghana, before the WHO recommended in 2021. The first vaccine to be recommended was RTSS. And then in 2023, they recommended the R21 matrix. Uganda preferred to use the R21 matrix, and it's the vaccine we have. And that is because it's more available.
Yes.
Given you saw how burdened we are.
Yes.
Everyone is at risk. Every part of Uganda, apart from a few districts,
Yes.
they are all at risk. So you can see our burden. We couldn't take on a vaccine that is available in low amounts. We needed one that was more available given our burden. So we took on the R21 matrix.
The R21 matrix.
Yes.
That's the vaccine
That's the vaccine that we picked. Yes.
Yes, and we can see that it works to prevent the severe forms of malaria and death, which is where most of our burden is.
Exactly.
So, like quickly, how safe is this vaccine? Because I know that's one of the major concerns. How safe is this vaccine? How effective is it?
Oh, the vaccine is very safe, and a lot of studies have been done around its effectiveness and for example, if I'm talking about effectiveness, the vaccine will reduce 13%. Okay, the available literature shows that it reduces over 13% of mortality, and it reduces about 35% of severe forms of malaria.
So was this, sorry to interject with a question. So this safety, was it, have these studies been done on the first vaccine you spoke to us about, the one that was first launched and released in the other countries, Ghana, Nigeria?
No, for both of them, yes, there's information available, although the first one was more studied. So it's effective in terms of reducing deaths, severe forms of malaria, but also hospitalization due to uncomplicated malaria. It is safe. The only known, like most drugs give us side effects. The only known side effects, and they are self-limiting, include fever. It's an injection, so pain at the injection site, irritability because of that pain, children cry a bit, and very rarely we like 1 to 2 out of 10,000 get febrile convulsions. The doctors know what febrile convulsions are. Majority of our children, 6 months to 6 years, whenever they have a temperature rise, they do get febrile convulsions. But normally febrile convulsions are self-limiting. But once you control fever, they never even happen. So febrile convulsions, but these are very, very rare. So the vaccine is very safe. The people, I know there has been a talk about the vaccine causing epilepsy that is not documented, death that is not documented. For example, the World Malaria Report of 2023, out of the 568,000 deaths, we had 440,000 deaths due to severe malaria among children, but there was no death that was associated with receiving the vaccine. That was 2023, and yet many countries were already giving the malaria vaccine. Yes, so it's safe. Maybe for eligibility, it's for children 6 to 11, are the ones eligible. It's not for adults. 6 to 11 are eligible to start. And for now, we are covering the moderate to high transmission districts, and these are 105. Probably when we come back, I can show which ones are these districts. Yes.
So this eligibility criteria of 6 to 11 months, you said. So this is because, should we assume this is because the greatest burden of malaria mortality was in the pediatric age group or the children?
Yeah, because the vaccines are not yet enough, we are prioritizing. So we had to prioritize the age group that is most affected by severe malaria and death, and that's the age group of below 5 years, and more so the ones below 2 years, because clearly, Dr. Kamala, you know that because we live in a malaria endemic country, by the time a child is born, because their mother has suffered enough episodes of malaria, they've shared the mother's antibodies. But these ones wane off by 6 months, and the child has nothing to protect them. So they are highly vulnerable. And by the time now they will be exposed to build that immunity, usually the first 1 year they have nothing at all, and that's why they are very prone to severe forms of malaria, and majority of them die. So they need a number of exposures. By about 2 years, they can maybe reduce the episodes of severe malaria. Then until 5 years now, that is when now they can fight off severe malaria and mainly remain as uncomplicated malaria. So that's why now we've come in to bridge that gap, protect them by giving them the vaccine.
Okay.
Yes.
So we are discussing the newly launched malaria vaccine, and right now we've just been talking about the vaccine and how it works, and it works primarily by preventing the severe forms of malaria and death, which is where our main concern is. And right now, we are seeing that it's being targeted towards the pediatric population, that's the children, and especially the children between 6 and 11 months who have a lower immunity and cannot fight off malaria, as well as the other age groups. So for now, that is the priority population, but in the future, we are hoping, of course, that as more and more work is done, even a vaccine can come out for the older children and adults and other age groups. So we are going to take a break, and when we come back, we shall continue our discussion, and this time we shall go into the rollout of the vaccine and how the vaccine is being rolled out and how it's being received so far. Thank you for watching the DOCtalk show, and stay with us.
You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Mommy, Daddy, Uncle, Auntie, Dada. I am healthy. I have a dose of the I wanna live long. Give me the jab. Give me protection. Give me the dose. Health is strong. Give me the jab. Give me protection. Give me the dose. Playing, I am growing. I am healthy. I have a dose of the jab, or drop. Jab, or drop.
Parents and caregivers, remember to immunize your children 9 times from birth to 18 months to protect them against vaccine-preventable diseases such as measles, rubella, polio, pneumonia, hepatitis B, tuberculosis, tetanus, meningitis, yellow fever, diarrhea, whooping cough, diphtheria, and malaria. All vaccines used for immunization are safe, effective, and free. This message is from the Ministry of Health with support from UNICEF, WHO, and partners.
It's a FlexiPay cashback explosion. Shop and pay with your FlexiPay. Cashback instant. It's a FlexiPay cashback explosion.
It's a FlexiPay cashback explosion. Simply shop and pay with your FlexiPay at activating outlets and enjoy instant cashbacks. Terms and conditions apply. Stanbic Bank is regulated by the Bank of Uganda, and customer deposits are protected by the Deposit Protection Fund up to 10 million Uganda shillings.
Hi, thank you for coming.
Thank you.
Oh, just a second. Where is your tax clearance certificate? You don't seem to have a tax clearance certificate, do you?
Oh no, I haven't filed my returns.
Sorry, we can't proceed without it. Can we bring in another bidder now?
Next.
Opportunities don't wait. Avoid penalties and interest by filing and paying your taxes before June 30th, 2025. Call our toll-free number or WhatsApp for help.
Uganda Revenue Authority. Developing Uganda together.
One-on-one with Michael Jordan Lukomwa.
A weekly face-to-face conversation focusing on accountability, inspiration, information, and sensitization of the public from the various sources, such as inspirational profiles.
Having a disability is not inability.
Professional guidance.
There is no special antiretroviral therapy that is given specifically for discordant couples.
And of course, politics.
Don't you see anywhere that you would give a credit in the fight against COVID?
My role as the owner of the country is not to, be preoccupied by giving credit to my servant.
We have said that if we are to talk to General Museveni, there must be certain conditions in place.
Is it true that you paid 5 million shillings to MPs that voted for Anita Monga and Tayebo?
That is laughable. Why would we pay when we have nominated them as SEC?
Every party has been represented in Uganda's parliament for 10 years. We only
by one MP, you yourself.
And my daughter, Susan.
Every Friday 9 p.m. it's One-on-One with Michael Jordan Lukomwa on UBC TV, inspiring Uganda.
You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Welcome back to the DOCtalk show. My name is Dr. Kamala Ivan, and this show is brought to you by the Ministry of Health and Kamala Men's Collection. So in today's episode, we are talking about the newly launched malaria vaccine. And earlier we were talking about the vaccine itself and how it works. And now we are going to go into how the vaccine is being rolled out and launched in Uganda. With me here, I have Dr. Jane Nabakooza, who is a pediatrician, and she's also a technical lead at the Ministry of Health in their malaria and chemo prevention and vaccine strategy. So we are going to now look at the implementation and impact of this vaccine. So I have to be honest with you. When I first heard about this vaccine, I thought this is awesome. Maybe now I can ditch the other preventive measures, the mosquito nets, the mosquito repellents, the sprays. So how safe is this assumption? Are we going to be able to let go of the other preventive measures? So how is it? How is this vaccine working alongside the other preventive measures?
Yes, the vaccine has to work alongside other existing malaria preventive measures. There's no single malaria intervention that can give you 100% impact. It has to be a package. So be the case with the malaria vaccine. Here we've seen how it works and where it works. So it can't work alone. Even when a child receives the malaria vaccine, in case they get a fever, they need to be taken to the hospital to make sure it's not malaria and to make sure it's not any other disease. Because remember, this is just preventing malaria, not any other disease. But then also, like we say, the vaccine will not prevent infection. So we need to keep all our interventions that prevent infection. There's evidence that shows that when you use, for example, the malaria vaccine and use the mosquito nets, you have very good case management. And in case you're dealing with children under 5 and you have a chemo preventive measure, like in Karamoja where we're doing seasonal malaria chemo prevention, that is when you can achieve about 98%. Because the number of limitations alongside. Let's take, for example, if you just say I'm going to use the malaria vaccine, clearly it's not going to prevent you from being infected. So the malaria vaccine works together with other interventions.
Yes.
Yeah, so these interventions Maybe I can quickly go through them.
Yes.
There are those that prevent you from being bitten by the mosquito that transmits malaria. These include the long-lasting insecticide-treated mosquito nets. Mosquito nets are given out every 3 years in campaign mode, and there we aim at achieving 100% coverage for all households in Uganda, whereby every 2 Ugandans in a particular household get a net between them. Because these are insecticide-treated mosquito nets, there's evidence that actually that gives you results, even if the 2 people are not sharing the net and sleeping under it together. Because there's a chemical repels the mosquito. So the mosquito population in the household reduces significantly, and the bites also reduce, and so is the transmission. But for you to have that, you need to have 85% households covered to have that desired impact. And so, because we want to maintain that all the time, we continue giving out mosquito nets during antenatal and in the API clinics, just to make sure that we have 85% at any given time. But that has to go along with use. People have to be using 100%, which is not the case, and you can see that's already a limitation. For where we have, but then we are spraying in the houses because the mosquitoes bite in the house and rest in the house after biting. So we spray the houses. Areas like West Nile, Bukedi, a bit of Busoga, we spraying. Then, of course, environmental management, we encourage the communities to keep the environment clean, free of breeding places of for mosquitoes, like stagnant water, the empty tires, the holes, name them. But we also encourage people to build well, like make sure they have wire mesh in the doors and windows, but then also clear bushes, possible plant mosquito repellent plants. And then, of course, the other one, after fighting the mosquito on that side, the other one is fighting the parasite. For the highly vulnerable, we give them chemo prevention for pregnant women. After 4 months or after 13 weeks of gestation, they start taking monthly intermittent preventive treatment of malaria and pregnancy with sulfadoxine pyrimethamine, commonly called Fansida. The sickle cell disease warriors, they are given monthly Fansida. The non-immune visitors are supposed to take prophylaxis. But then also we encourage prompt treatment seeking for prompt diagnosis and treatment of malaria, because whenever you delay in a house without taking care, your reservoir, you're transmitting. I also encourage completion of treatment. There's also fighting against malaria. And now the malaria vaccine.
Right.
Yes.
So
intervention.
Yes. So we have lots of preventive measures already available, but the vaccine is of course a groundbreaking one, a bit special because now at least we have the chance to prevent the very severe forms of malaria. So now, like with all vaccines, there are going to be myths and misconceptions. There are going to be fears. So how are you dealing with the hesitancy, vaccine hesitancy? How are you dealing with it countrywide as you're trying to roll out this vaccine?
Yeah, what I'm doing right now is one of the ways. We're trying to educate people. It's normal for one to fear. It's normal for one to be hesitant. But you need to keep talking to people about you compare risk. If fearing to get sterile because of the vaccine, how about dying because of malaria? How about getting disabled because of malaria? So you try to help people weigh the risks against the benefits. You also now talk about the benefit of using the vaccine. You try to understand their fears and keep talking to them. Like clearly the word is misconception. Someone has conceived something wrongly. What is this that they've conceived wrongly? Go out and talk to them. One of the ways we're using is through talk shows like this, through radio messages, radio spots, but those work for certain class. So we're also going social media because there's that group that does social media. But one of the commonly used avenues is interpersonal communication. Our health workers, we've given them messages, keep sharing with people, and we're trying to backtrack and get all these myths and misconceptions, things that people fear. What are the anti-vaxxers saying? And we don't come out directly to do a rebuttal. We take time to understand, look for the star. We synthesize science and come out to like give them the facts. And we've gone an extra mile by the way. We're not stopping at the health workers and health education at the health facilities. We also have our community health workers, village health teams. We've given them messages. These people visit homes, they go house to house occasionally, and they talk about generally health, but to make sure they have something on vaccines there, including the malaria vaccine.
I wonder, do they inform them also about the mortality? Because when I think about malaria, it's quite a dismay. It's quite dismaying that even after all this time, when you look at the WHO mortality database, malaria still ranks among our top 10 causes of death. Like when you look at all age groups and all causes of death, we still have malaria ranking, I think, is it number 1 still? If you look at all cause mortality and all ages, still number 1. So I wonder whether we also share this information.
Looked at data, in most places, malaria ranks number 1 in terms of death and causing illness. So we try to use those numbers to craft messages. But you also know that at times our people death doesn't scare them a lot. So we're also trying to factor in the socioeconomic impact. Because I'm telling you, everyone loves money. No one wants to be poor. So we're also trying to go how much poverty is malaria causing. To show people how bad malaria is and the different ways in which malaria is affecting us. I mean, people in the village there will want to have their children educated and excel in academics. But if you try to show them that, well, even if you're longing for that, but once your child has malaria, they'll never get there. Try to find a way of designing messages around things that matter to people.
Exactly.
Because in Uganda, what matters to you does not matter to me.
It's true.
So we are trying to understand the different groups of people. And we're using peer-to-peer, VHTs, community health workers. Go down there to mobilize. We're using cultural leaders. We're working with cultural leaders, religious leaders, like influential people. So we're really trying, and like I told you, we are number tracking. If we pick anything, we try to give an explanation, try to make people understand using the channels that are appropriate to different groups of people, and using working together with people that are influential to pass on these messages. And this that we're trying to address myths and misconceptions.
Okay.
They have to be there. This that we're trying to address hesitancy. We're trying to relieve fears and for coming. Yes, we're doing a lot of work, but it's a dynamic situation. What works today may not work tomorrow.
Exactly.
So you need to be looking out for what may work better the next day, what works better for this other population, what doesn't work for that population, although it worked for this one. So it's not an easy thing, but we're trying our best.
Yes.
But,
So I'm curious.
So we are trying to work more, do a lot of community engagement. Like get the people themselves to those that we convince others.
Okay.
Trying to do.
Yes. So I'm curious personally. So we have our mandatory vaccines that we give to all children in Uganda. There is a vaccine schedule that all children in Uganda get. So are there plans to include the malaria vaccine onto that schedule?
Yeah, the malaria vaccine introduction is actually not a campaign. We are fitting it into a routine immunization where we are providing these other vaccines. The vaccines are given at the facilities where we already vaccinated. And this is where mothers are going to take their children to receive.
So thank you, Dr. Jane, for that. So Dr. Jane has given us an overview of how this vaccine is being launched and rolled out in the country, and how we are trying to encourage people to get the vaccine, how we are trying to deal with the vaccine hesitancy. So we are going to take a short break, and when we'll come back, we shall finally look at the different ways we are encouraging people to use the vaccine, and the overall message on the vaccine. Thank you for watching the DOCtalk show, and please stay with us.
You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Crafted with precision, designed for brilliance, Supreme Wave pens reach the hands that shape tomorrow. Only a Supreme Wave delivers expression this pure. In every stroke, confidence flows. Because greatness isn't guessed, it's written. Supreme Wave, write your future.
Supreme Wave are the best.
You are watching the DOCtalk show.
This message is from the Ministry of Health with support from partners.
Welcome back to the DOCtalk show, and thank you for joining us. My name is Dr. Kamala Ivan, and this show is brought to you by the Ministry of Health and Kamala Men's Collection. On today's episode, we have been talking about the newly launched malaria vaccine, and earlier we were talking about how the vaccine is being rolled out and distributed. I'm joined today by Dr. Jane Nabakooza, who's a pediatrician, and she's also the technical lead at the Ministry of Health in the malaria chemoprevention and vaccine program. So now we are going to go into how the vaccine is being rolled out. So earlier you told us that the vaccine is going to be given alongside other vaccines. So when is this starting, and where is this starting?
Yes, we launched the vaccine. Uganda became the 18th country to introduce the vaccine. We launched on the 2nd of April. And so just a day ago, we made 2 months since we introduced the vaccine. This vaccine is available in the 105 districts that are moderate to high transmission. Just to quickly break it down, these districts include the entire West Nile, the entire Acholi region, the entire Lango region, the entire Karamoja region, the entire Teso region, the entire Bukedi region, the entire Busoga region. We don't have any district in Sebei. Mbale just has about 5 districts. North Buganda, Kampala, Wakiso, and Mpigi are not introducing the vaccine for now. South Buganda, Kalangala is not introducing. Ankole, we have about 5 districts. Chigezi, we only have Kanungu. Renzori, we just have 4 districts. Bunyoro, we only have Bulisa, Chikube, Chiriandongo, and Masindi. The rest are not introducing until after 2026 because the vaccines were not enough. We started with those districts that are moderate to high transmission. And the vaccine, like I said, it's for it will start with children 6 to 11 months. So the first 3 primary doses are given every month. A child has to go back every month. Take, for example, a child that starts at 6 months will get the first dose at 6, the next dose at 7, the next dose at 8. Then they come back after 10 months, that's at 1.5 years, to get their 4th dose. For a child to be fully protected against severe forms of malaria and death, they must complete the 4 doses. The vaccine is an injection on the right hand. And so Any child that starts should complete. This is a request that every child that starts should complete. So what that means that if a child starts, for as long as they are still below 5 years, whenever we get them, we try to support them to get all 4 doses. But the best would be if they would get their 3 doses every 3 months and then complete within.
Inspiring Uganda.